Hello, we are going to speak about the technique of endoscopic third ventriculostomy, and the first part of this course will be what happens outside the ventricles before you are doing really the endoscopy. So first, how do we position the patient? The table must be low so that you can be at ease. The patient's head should be straight, slightly elevated and flexed in order to avoid spillage of CSF. And you have to warn the anesthetist that intubation can become selective when you flex the head. You use a horseshoe headrest. I think there's no need for a pin headrest, especially in small children. And you have to be very wary about the ergonomics. You have to face the screen. You don't need to make excessive moves, so you use a two-hand grip on the endoscope. You keep your elbows along your waist, and one hand should always be in contact with the patient's head to avoid excessive movements once your endoscope is inside the patient's brain. You take your landmarks. It's very important that you can palpate the coronal. Very often it is split because of the intracranial hypertension. You use a landmark 1 centimeter ahead of the coronal suture. You have to locate the midline and to aim 2 centimeters away from the midline. Then once you have draped the patient, you can palpate the nasion through the drape. Gives you a very good landmark. Should we use a pupillary line? I think this is misleading because, as you can see, with just an error of a few degrees, you can have amplification of this error to 1 or 2 centimeters. So I think this should be avoided. I prefer aiming at the cell lattice. You have to imagine through the skull of the patient, the place of the celatosica, because it gives you a very good alignment with the foramen of Monroe. Do you use navigation? I do in some selected cases when the ventricles are small, but in most cases you don't need it. Then you incise the scalp. I think it's important to make an arciform incision, not to use linear incision, because in this case the incision is just above the hole in the dura. You can have CSF leakage, especially if it is a redo surgery, as in this case. The incision should be perpendicular to the surface, because if you do a skewed incision, you have a very bad closure. So, you elevate, and when you do the closure, you should avoid non-inverted knots and use only inverted knots for the subcutaneous layer. Then you elevate the scalp and the periosteum together using a regime, especially like obligatory regime. Then you open the bone. You can use a motor, of course, but I prefer using the Hudson brace because motors are cumbersome. It is something more that is put on the patient's body. And when you do the burr hole, you have to be aware that the sutures are often split. There can be a cranial tabes because of chronic intracranial hypertension. So be careful not to slip into the suture when you do the burr hole. Then in some babies, the fontanelle is not closed, so you just incise it with a number 11 blade. The dural opening is also done with the number 11 blade. You use a linear incision whenever it's possible, because if it is well incised, it can be easily sutured for the closure. If you use a large endoscope like a minor, it's better to do a cruciform incision, because otherwise you cannot penetrate with the endoscope. If you encounter a venous bleeding, you have to coagulate using the bipolar. But sometimes it can be difficult to coagulate because you can have dural lakes just under your burr hole. And if bleeding persists, you just do hemostasis with some Surgicel, some wax sometimes, and make another access anteriorly and keeping the same distance from the midline. Then you introduce the endoscope. I prefer introducing it arm held, because you can have, it's very important to have a good, once you have your good landmarks by palpating the nasions with the drapes, you adjust the arm so that you can create a stereotaxy-like alignment between the burr hole and your aim, which is, as I said, the sedator ceca. Then you loosen the grip and you descend the endoscope about 5 centimeters, according to the measurement you have done on imaging before surgery. And then you tighten the grip again, you aspirate, you inspect the lumen of the endoscope, you see CSF, so it's okay, you can descend the optic. Once you have done the endoscopy, of course, you have to close, obliterate the channel to the brain mantle by Surgicel. You pack Surgicel like a nice cone-shaped pack of Surgicel. It will not prevent CSF from escaping, but it will. The aim is to prevent blood and bone dust to contaminate the ventricles. You close the dura if possible using a 4-0 prolane. You can use bone dust to obliterate the hole. You close the galea with a 3-0 rapid with inverted knots, as I said earlier, and you use 3-0 rapid for the skin or 4-0 prolane in small infants. You avoid triangular needles because it can create CSF leakage. So I thank you for your attention, and I see you soon for the second part of this course. You can see more information on our website and more videos on YouTube.